I think when you start presenting like this only, that's okay.
Yes, sir. Good evening, sir, and my colleague. Today's my case is 60-year-old female patient, housewife, hailing from Kerala, presented with a complaint of bleeding per rectum, mucus discharge per rectum, and altered bowel habits since 6 months. Coming to history of present illness, so my patient was apparently asymptomatic 6 months before. Then she started having altered bowel habits and bleeding per rectum. Initially, she developed episodes of constipation lasting few days, followed by loose stool. She had passage of loose stool containing mucus and small amount of blood, which is fresh red, which was fresh red in color, small in quantity, mixed with stool up to 3 to 4 times per day, and was not associated with pain while passing stool. She had lower abdominal discomfort, which improved with passage of stool, and she also had sensation of incomplete evacuation. Uh, she also had history of unintentional weight loss of 6 kg over 3 months. She did not have any episodes of severe abdominal pain, distension, nausea, or vomiting. She was also not complaining of melena, hematemesis, straining while defecation, urgency, or any narrowing of fecal stream, or any fecal incontinence. There was no history of mass coming out per rectum, or any urinary complaints or vaginal foul smelling discharge. There was no history of any skin lesion or past history of similar complaints before 6 months, or any jaundice, cough, hemoptysis, or back pain and bone pain. For this complaint, she took over-the-counter medication for a few days, but symptoms did not improve. So she was evaluated at local hospital and referred to higher center for further management.
So what do you make out of this history? Can you summarize the history?
Yes, sir. So my patient is a 65-year-old female patient without any, she's hypertensive, sir, with a complaint of altered bowel habits, followed by 3 to 4 times of loose stool containing blood and mucus with stool, and also there is history of incomplete evacuation with a significant loss of weight over the past 3 months, sir, without any obstructive feature.
Yeah, so right, but in the summary, comorbidities should not come in the beginning. See, there is a difference between presenting a case in the ward round, where the main purpose is management of the patient, versus case presentation in an exam, where the main purpose is to arrive at a diagnosis. The comorbidities are important, but they need to be mentioned later. And in the summary, unless it is some very important point, there is no need to mention. So summary should be as crisp as possible, which means that you should not be using any unnecessary words. So here the age is important, the duration of illness is important, the fact, what is the most important symptom in this patient?
Altered bowel habit with bleeding per rectum.
Bleeding per rectum is the most, if an elderly, even if she didn't have alteration of bowel habit, if she had only bleeding, then also the interpretation will be same. On the other hand, if she had alteration of bowel habit only and no bleeding, then the thought process will be different. So whenever there is bleeding, that becomes the key symptom. So bleeding is the most important symptom. Others are associated, supporting. So the summary should include important positive and relevant negative points. For example, good that you mentioned that she has no features to suggest obstruction. That's important. Okay. So what is your analysis of this history? So, suppose this was a male patient. Would your summary, or should your summary have included something else, which in a female patient may not be that important?
Any urinary symptoms are
very important. So when you are dealing with a male patient and your suspicion is CA rectum, you have to mention urinary symptoms in more detail. And it should be mentioned as a separate line so that the examiner gets an impression that, yes, you know about this. And I personally, at MCH level, when your history is strongly suggesting a rectal pathology, I probably would not even mention hematemesis, because you don't expect this patient to have hematemesis, isn't it? So
Yes.
even if you don't mention it, it is all right with me, because if you do mention it, somebody may ask, why did you ask about hematemesis? And then you would say, no, there is no relationship. I asked it just as a routine. So there is a slight difference in the presentation of history by an MBBS or even MS student versus at your level, where we want a targeted history. So based on the presenting symptoms, you probably have made your mind as to which organ, which system is involved, and what are the likely associated symptoms, and you mention only those. Similarly, you mentioned about hemoptysis. Why did you
Yes.
mention hemoptysis?
So as a part of the symptoms of any metastatic disease, I want to rule out any lung metastasis. So
What is
by
the
breathlessness.
what is the presentation of lung metastasis?
Usually, sir, it might be asymptomatic, and most commonly it is detected on the follow-up evaluation with phase C, and then we investigate further cause. Or else it might present with any large volume or any obstructing the airway, then breathlessness or hemoptysis rarely may develop.
So there is a difference between pulmonary metastasis and pleural metastasis. Pulmonary metastasis would cause what are known as solitary pulmonary nodules seen on chest X-ray or chest CT. Usually they are asymptomatic. They are detected when you image the chest.
Yeah.
If at all, they would cause a new onset persistent cough because of bronchial irritation. Very late when the tumor erodes into the trachea or the bronchial tree, would you have hemoptysis. So hemoptysis is not a common symptom of pulmonary metastasis. Pleural metastasis will cause malignant pleural effusion, which, as opposed to nutritional pleural effusion, which is usually bilateral, is usually unilateral. So if you see large unilateral pleural effusion, either clinically or on investigation, then you start suspecting a malignant pleural effusion, and the symptoms caused by that will be a dull aching pain on that side of chest, and more importantly, breathlessness on exertion, dyspnea on exertion. So when you are mentioning metastatic workup, it is more important to mention dyspnea on exertion or unilateral chest pain, recent onset cough, and then maybe you can mention metastasis. Liver metastasis, there are no specific symptoms. They are same symptoms which are that of malignancy. Many students wrongly mention jaundice. Jaundice is not a presentation of liver metastasis unless there is a large metastasis at the hilum which is pressing on one of the bile ducts, or the liver is studded with metastasis. But that is a rare presentation. The symptoms of liver metastasis are general asthenia, anorexia, weight loss, which could be there without metastasis also. Bone metastasis, you should mention if there is any history of, again, new onset persistent bone pain or pathological fracture with previous trauma. Brain metastasis, again, new onset persistent headache, vomiting, and in late stages, convulsions or focal deficit. But that is uncommon, that is rare. So that is how you should present the metastatic workup. Okay, so what is your interpretation of this history?
So I would like to give the first differential diagnosis of malignancy of the colorectum, mostly involved in the left side of the colon or rectum. And then I would like to give, I cannot rule out, sir, possibility of, though less likely, possibility of inflammatory bowel disease with this history. So, but first I would like to rule out, sir, malignancy. So
Why do you say malignancy? Why do you say malignancy?
Because here's a 60-year-old female patient, elderly patient with a history of bleeding per rectum, which is significant, and with a short duration of 3 months, and with a significant loss of weight, and there is also alteration in the bowel habit in the form of initial constipation followed by diarrhea mixed with stool. So these are pointers in favor of malignancy.
Yeah, so age, recent onset, bleeding per rectum, alteration of bowel habit, which is again recent, and the sense of incomplete evacuation, isn't it? And then the weight loss. What is the commonest cause of bleeding per rectum at any age?
Hemorrhoid, rectal polyp.
Hemorrhoids. So why is this not hemorrhoids?
Because sir, bleeding is mixed with stool, and also it is a long-standing 6 month history with bleeding mixed with stool, and also loss of weight is there, sir. So I would not consider, and there's also no straining or any persistent constipation which may lead to bleeding at the end of defecation. So no typical peculiarity of bleeding per rectum also hemorrhoids.
So the classical clinical presentation of hemorrhoids is that the patient is usually constipated. There is a history of either straining or passage of a hard piccolith, following which there is a splash of fresh red blood, which is not mixed with stool. So stool is not mixed with blood, but after the passage of stool, or if it is straining, even before the passage of stool, there is a splash of fresh red blood. There is no pain. There is no sense of incomplete evacuation. And except for the constipation, there is no alteration of bowel habit. So that is why in this case, you would say that this doesn't look like hemorrhoids. Okay. So you said left colon. How can you localize that it is left colon?
Because sir, there are few symptoms suggestive of left-sided colonic or upper rectal malignancy, which includes the fresh bleeding per rectum. There is also a history of incomplete evacuation, and also there is no history of straining or urgency, but there is history of mainly incomplete evacuation and fresh bleeding per rectum. So these two are pointers.
Fresh bleeding per rectum and incomplete sense of evacuation, what does it suggest?
It suggests a diffuse source of bleeding, sir. So,
rectum. So rectum is more likely than left colon, isn't it? Why should left colon produce sense of incomplete evacuation? It should not. And so if you have fresh red blood, if you have sense of incomplete evacuation, if you have a feeling of tenesmus, these are the symptoms which strongly suggest that the lesion is in the rectum. What do you mean by tenesmus?
tenesmus is a painful urge to defecate without a resultant defecation with passage of blood and mucus.
Yes.
So
If you have those symptoms, again, so in this case, most of the symptoms are suggestive of rectal rather than colonic involvement. So based on the history, it would be better to say that I am suspecting that this is a malignant lesion, and the most likely side, I think, is the rectum. Now, your second diagnosis you said was inflammatory bowel disease. What are the points in favor of inflammatory bowel disease?
So, sir, likely symptoms in favor are increased frequency, though it was initially constipation, but later on there is a history of increased frequency of stool 3 to 4 times per day with blood mixed with stool and also mucus discharge. So this is the main pointer towards the inflammatory bowel disease. And there is also loss of weight might be there in inflammatory bowel disease also. So it cannot rule out inflammatory bowel disease. And also this is the second peak of presentation of inflammatory bowel disease. So
yeah, so you inflammatory bowel disease you diagnose when there is a history of loose motions with blood, mucus, and pus. Okay.
yes.
Now, can you have loose motions with blood and mucus in rectal malignancy also?
In case of sir, though less likely, loose stool are not common presentation, but in case of in the background of polyposis syndrome, this might occur. Sir.
Which syndrome?
Otherwise, any hereditary polyposis syndrome, when there is a diffuse polyps throughout the colon with malignancy in the rectum, then loose stool might occur. Otherwise, only loose stool is not a common presentation of rectal malignancy.
What is spurious diarrhea?
Spurious diarrhea is, sir, it usually occurs in the early morning when overnight bleeding and mucus discharge accumulates in the rectum, and when patient has a urge to pass the stool, and when it goes early morning in the first visit to toilet, Then there is a passage of blood and mucus per rectum. Sir.
So spurious diarrhea, does it always have to include blood? Can it not be mucus alone?
It can be mucus discharge alone also.
So spurious diarrhea means that actually the patient is not having diarrhea. There is no increased frequency of stools, but there is increased passage of stool. And actually the patient doesn't pass stool. The patient only passes mucus. So two ways by which spurious diarrhea can occur. One, when there is fecal impaction. Suppose elderly patient who has fecal impaction. Now the patient is not able to pass that fecalith, but that fecalith is causing irritation of the rectal mucosa, and a lot of mucus is being secreted, which collects, and then either because of weakness of the sphincter or rectal sensation, anorectal sensation, the patient passes, which he calls stools, but it is mainly mucus. Second is when there is a large intraluminal polypoidal growth in the rectum, it behaves the same way. So not only it causes irritation of the rectal mucosa around, but even the surface of the polypoidal growth can secrete a lot of mucus. So that is what is known as spurious diarrhea. Now, in order to differentiate between rectal growth causing spurious diarrhea versus IBD causing diarrhea, actual diarrhea, real diarrhea with blood, mucus and pus, you have to very carefully elicit the history. In IBD, the patient will never have constipation, isn't it? It will always be loose motion. So if the patient says that in between I am constipated and then some days or some time I pass loose motion, that is more likely to be alternating constipation and diarrhea, which is more suggestive towards a malignancy. So at your level, we expect that you carefully elicit the history and then give your interpretation. The way you have described this patient's history, it doesn't look like as if the patient is having frequent loose stools with blood and mucus. So that is why IBD is less likely. And as I said, if it is a male patient, you have to make a specific, special, highlighted mention. You have to emphasize and don't just say no history of any urinary symptoms. You say there is no history of frequency, burning, dysuria, hematuria, which means that you have asked for these symptoms. Okay?
Yeah.
What about pain?
As a patient is not giving history of pain while defecation. But if it is present, then it will suggest involvement of a sphincter muscle or locally advanced lesion. But there is no issue of pain while passing defecation.
So how can the patients with rectal cancer have pain, and how they can have pain, and what kind of pain?
So pain is typically of heaviness type of pain, and it is usually, it can be either due to sphincter involvement or locally infiltrative growth involving either the prostate or sacrum posteriorly infiltration.
Why should sphincter involvement cause pain? Is sphincter a sensitive structure? Is it it's a smooth muscle. Just as rectal wall is involved, doesn't cause pain. Why should sphincter involvement cause pain? What causes pain in rectal cancer? What is the commonest cause of pain in rectal cancer?
So, in low rectal cancer involving the sensory mucosa at the level of anodome and dentate line.
That is more likely. So if it is a lower rectal growth and it extends into the anal canal, the anal skin, which is sensitive. Okay, agreed. Any other cause? Suppose I say, no, it is not in the lower rectum. It is in the mid or even upper rectum. Can it cause pain?
So then infiltration of the pelvic nerves, which are present in the posterolateral pelvic wall. So infiltration or invasion of nerve plexus may cause.
So whenever you give an answer, you should give complete answer showing all your knowledge. So say that a posteriorly placed rectal growth, when it infiltrates the retrorectal presacral plexus of nerves, it can cause pain. Then the parietes means pelvic wall, lateral wall, posterior wall. When it is involved, then it can cause pain because there you have skeletal muscles. Parietes have skeletal muscle. So skeletal muscle involvement will cause pain. Parietal peritoneum involvement will cause pain. Okay. Any other? Can they have pain at any other side? Patients with rectal cancer? other than local? So they can have pain in the limbs, isn't it? Because of the involvement of the presacral plexus. And
Yes.
any other, can they have a remote site of pain? Can a patient with rectal cancer have a remote site of pain? Can the patient have dull aching pain in the loins?
Patient may develop, if there is a metastatic lymph node in the external iliac group of lymph nodes are involved, then
Lymph node enlargement usually doesn't cause pain unless it is a large, bulky nodal mass, which again is infiltrating some nerve. You can have ureteric obstruction causing hydroureter and hydronephrosis. So that not common, but patient can have pain in the loin because of hydronephrosis. Okay, let's move on to examination.
So, sir, my past family history, there is no significant family history, no similar complaint in the family, and I would like to know the detailed history of any colorectal cancer or any other malignancy, including uterine or ovarian malignancy or any risk of inflammatory bowel disease in the first or second degree relative. I would like to inquire in detail, sir, but there is no significant family history. And in the personal history is also normal. She takes mixed diet. There is no history of any addiction. Breeder habits are regular. She has 2 children, uh, yes, sir. These are about the history. And now coming to examination.
So family history here, of course, the patient is 60 plus, and still you should mention, but especially if you have a young patient and you are making a diagnosis of a colorectal cancer, then you should mention the family history in little more detail. Again, one way is that there is no family history. The other is that you say that none of his first degree relatives, that is grandparents, parents, siblings, children, have either a history to suggest a colorectal cancer or have had a death at a young age. Suppose somebody died at a young age, then you have to suspect what was wrong with that. So it should be little more detailed presentation. And then, of course, other related cancers, so especially in females, the genital tract cancers.
Yes.
Yes.
So now coming to sir examination part. On general physical examination, patient is conscious, cooperative, and foreign, moderately built and nourished. BMI is 21.7 kilogram per meter square. ECOG performance status is 0, sir. There is no evidence of any icterus, failure, generalized lymphadenopathy or pedal edema. There is no evidence of supraclavicular lymphadenopathy or inguinal lymphadenopathy, sir. Patient is afebrile. Blood pressure is 110/70 and in his right upper arm supine position. Pulse is 90 beats per minute. And the respiratory rate is 14 beats per minute, 14 per minute, sir. On coming to systemic examination for abdomen on inspection, scaphoid, umbilical is central and inverted. Essentially, it is within normal limits, sir. There is no flank fullness and no scar sinuses, pulsation, peristalsis, or dilated veins. On palpation, I have confirmed my inspectory findings. It is also essentially within normal limit and no palpable lump, no any evidence of raised ulcer. On percussion, flank side tympanic, liver span is dullness starts into 15 intercostal space, and liver span is I have been provided, so it is 14 centimeter in mid-clavicular line. So I suspect it is a little enlarged. And auscultations are normal bowel sound are present, no buoy or normal. And on rectal examination, perianal skin is normal, sir. There is no fissure and fistula. Sphincter tone is normal. Glow stained with yellow cases, and there is no any palpable mass or any nodularity. I could find. I have been not given proctoscopic examination and pervaginal examination, but I would like to do the proctoscopic examination and also pervaginal examination.
Yes.
And the rest of the examination is within normal limits.
So you said no lumps palpable in the abdomen. What lump you were looking for in a patient with C. rectum in the abdomen?
So that I have looked retrospectively, because on percussion liver span was given as 14 centimeters. So I would like to see if any other palpable lump is there or not. So liver is uniformly enlarged, or is any other nodularity or asymmetric enlargement. I would like to know those details.
No, no. So if the liver span is 14 centimeter, it's normal. What lumps you were looking for in the abdomen?
Basically, sir, liver enlargement only, sir. Irregular to look for any
That is not
metastatic.
lump. Liver enlargement is not lump. Liver enlargement is hepatomegaly or organomegaly. Spleen enlargement is not a lump, splenomegaly. Lump means that you were looking for some other lump. So what lump could be palpable in a patient with CA rectum?
Sir, if it is obstructed, then distended bowel loops can be palpable, sir.
That again is
Or,
a lump, that is distended bowel.
yes, sir.
So two things or maybe three you can say. One is that if there is a synchronous malignancy, isn't it? It is possible. So if there is a synchronous malignancy, say in the right colon, in the transverse colon, in the left colon, in the sigmoid, that lump could be palpable, number one. Number two, not in this case, but suppose there is a rectosigmoid growth and there is obstruction and there is fecal impaction. So in a thin-built patient, a proximal colon, which is full of fecal matter, it can be palpable as a lump, as an indentable lump. That will be a soft lump, which you can indent. So that is one possibility. Third possibility is an large omental or peritoneal deposit, which could be palpable as a lump. And very, very rarely, as we were discussing earlier, lymph nodes, but these lymph nodes are usually retroperitoneal, very, very unlikely that they would be palpable. The only nodes which, when they are enlarged, produce a lump are para-aortic nodes, especially from a testicular tumor. Large para-aortic nodes, sometimes they present an epigastric lump. So that is why whenever you have a patient with epigastric lump, I know that in your exam you will never get a testicular tumor, but you should always mention that. Many students have failed in MS exam when they had a patient with epigastric lump and they did not examine the scrotum. So you have to mention scrotal examination in every patient with an upper abdominal lump, or even iliac fossa lump, because it could be that on one side there is an undescended testis. So that is what you feel. And you said that there is no ascites on your palpation. When you were at palpation, you should not talk about ascites at the end of palpation. You should talk about ascites at the end of percussion. Now, you get different types of examiners in your exam. There will be some like me who at this level will accept when you say there is no free fluid in the abdomen. But there are others who insist that you should describe your examination like an MBBS student. So instead of giving your interpretation, you should describe the findings. You should say that the flanks are not dull. You should say that there is no shifting dullness if the flanks are dull. And then maybe you can add that there is no ascites. Okay.
Okay. Yeah.
So how does the examination add to your history? Does it change your interpretation or analysis?
No, sir. Actually, patient is preserved. Patient is relatively preserved with perform status of 0. And I could not find any lesion in the colorectal examination.
So you can say, so you can say that the growth is not, at least in the lower rectum or lower part of the mid rectum, because that would be palpable with a normal index finger. Second, you can say that patient is nutritionally and performance-wise well preserved. Third, you can say that there is no clinical evidence of metastatic disease, isn't it? So that is what, when you have a normal examination, you should give your assessment. Okay. So now this patient comes to you in the OPD. What will you do?
I have not been provided with proctoscopic examination. So I would like to first do proctoscopic examination also in this patient. And provided if it is also normal limits, then I would like to review the previous records if any has been done for evaluation of the patient.
No, she comes to you as a new patient. She hasn't had any previous investigations. So you would do a proctoscopy.
Yes.
What do you mean by proctoscopy?
By that means I would like to visualize the rectal mucosa and if any growth is visible through the lumen of the proctoscope. And if it is accessible, then I can take biopsy also directly under the guidance of proctoscopic examination.
So does proctoscopy evaluate the entire rectum?
No, sir. It is can evaluate only lower and lower portion of the middle rectum, around 10 to 12 centimeters of the
Yeah, so you
length.
should say that the routine proctoscopy with the normal sized proctoscope does not evaluate the entire rectum. So a normal proctoscopy does not exclude a diagnosis of CA rectum.
Rectum.
And in the same breath, you should say that if the proctoscopy is normal, then I would go on to do a
Colonoscopy, provided the basic blood investigation, including the hemogram, is within normal limits.
So what are the
I would
types
do
of colonoscopies?
colonoscopy can be, sir, normal adult colonoscopy, and it can be either sigmoidoscopy or colonoscopy, and it can be also classified as an adult colonoscopy, and if not possible, then pediatric colonoscopy can also be used. Otherwise, rigid sigmoidoscopy or full colonoscopy.
You should know the difference. One is anoproctoscopy, the OPD procedure, which is maybe 10 centimeter, 12 centimeter. There are long proctoscopes also. And as we discussed, it does not evaluate the complete rectum up to the rectosigmoid. Second is a proctosigmoidoscope, which again is a rigid instrument. That, yes, will evaluate the entire rectum and some part of the sigmoid colon. Next is a short colonoscope, which is a flexible equipment. So that evaluates the rectum, the sigmoid, and maybe some part of the descending colon, depending upon the length and tortuosity or redundancy of the sigmoid colon. And last is the total colonoscope or a full colonoscopy. So these are different investigations. If your suspicion is that you are dealing with a tumor in the rectum or rectosigmoid, then for looking at the lesion, for obtaining a biopsy, a proctosigmoidoscopy or a short colonoscopy will be good enough, which can be done as a OPD or an office procedure, whereas full-length colonoscopy may require preparation, and some people may want to do it under fluoroscopic control because it takes time. It may be difficult. So for diagnosis, what you require is a proctosigmoidoscopy or a short colonoscopy. Do we have the reports of these investigations? Yes.
Am I audible?
Yes.
Yes, sir. So hemogram shows hemoglobin.
No. Tell us about proctoscopy first.
Proctoscopy was normal, sir. Before the sigmoidoscopy, it was done. Can I discuss the sigmoidoscopy report, sir?
Yes, please go ahead.
Yes, so
sorry, the other thing which, if there was a strong suspicion or one of the differential diagnosis was IBD, you have to say that a normal rectal mucosa on proctoscopy would, to a great extent, not 100%, to a great extent rule out at least ulcerative colitis, because we know that rectal sparing ulcerative colitis is not very common. Of course, it can still be there, that rectum is spared, so you have to look at the proximal colon, and obviously Crohn's disease still remains a possibility. Yes. So what does the sigmoidoscopy show?
So the scope passed up to the sigmoid colon, circumferential proliferative friable mass lesion with luminal narrowing involving sigmoid colon. Biopsy was taken. 6 mm diminutive sessile polyp in the rectosigmoid at the rectosigmoid junction, and scope could not be negotiated across. Conclusion was carcinoma sigmoid colon with luminal narrowing, diminutive sessile polyp at the rectosigmoid junction, and suggestion is to go ahead with the CCT abdomen.
So what do you make out of this report?
So, sir, it shows the rectosigmoid growth. The exact distance from the anal verge of the lower border of the mass has not been given. So, I would like to know the.
Does it matter? Does it matter? Obviously, this growth is beyond the rectosigmoid because they have said it is in the sigmoid, isn't it?
Yes.
So in a growth which is in the sigmoid, does it matter whether it is 20 centimeter, 25 centimeter, 30 centimeter?
No,
it doesn't.
Sigmoid growth, it doesn't matter, but if it is involving the rectum, then
yeah,
I would like
you should not talk of the distance from the anal verge in a sigmoid growth. it has no relevance, it has no importance, it has no meaning. Okay.
Yes.
Yes.
And
What about
it
the,
also
yes.
triable also growth with diminutive polyp in the rectal at the rectal sigmoid junction. So biopsy should be taken from the mass lesion also, and that polyp may not be required polyp biopsy from that polyp, because it will not change our plan. So I would like to know the biopsy report.
So you
And
are
it
not
is an
saying,
obstructive lesion, sir. It is growth scope is not passing beyond the growth.
you are not
It
giving
is
any,
legal.
you are not giving any importance to that polyp.
I am giving, sir, but I would if this polyp is only present, then it will not change my management. If other polyps are present proximally throughout the colon, then I have to take other plan.
So in which situation you are more likely to have other polyps?
In hereditary non-polyposis colon cancer, which segment with mucopathotic segment malignancy, or any other
Dr. Jazeel, your audio is on. Please mute yourself.
or any other polyposis syndrome in the background of polyposis syndrome, this malignancy has developed. Then I would expect polyps in this.
I would say that if they have seen only one small polyp up to the sigmoid, then it is less likely that it is a polyposis syndrome, because in polyposis you would have expected to see multiple polyps. But still it is possible that up to this level only one polyp is there, and proximally there are more polyps. So that is more likely if this polyp is adenomatous polyp. And that is why whenever you see a polyp, it is always better that while you are taking the biopsy from the primary lesion, you also remove the polyp. It's a small polyp, it can easily be removed and subjected to histology. Suppose it comes as a hyperplastic polyp, then you are not worried.
Yeah.
But if it comes as adenomatous polyp, then you are worried. Okay, so how do you evaluate the colon? Because they could not pass the scope beyond.
So if possible and facilities available, then pediatric colonoscope can be used if it negotiates the lumen.
Okay, that also doesn't go.
And sir, other options are CT scan with, and if there is no colon is not loaded with stool, then CT colonography is another option to see whether the polyps are present throughout the lumen of the colon or not. So by imaging, we can evaluate cross-sectional imaging. Sir.
So how do you compare CT colonography? What is another name for CT colonography?
Virtual colonoscopy.
Virtual colonoscopy. So what is the difference between virtual and real colonoscopy?
So it is a three-dimensional reconstruction of the colonic lumen with the help of software.
I didn't listen to the question. I didn't ask you what is virtual colonoscopy. I asked you what is the difference between virtual and real. So you have to tell advantages and disadvantages of both.
So real colonoscopy can have diagnostic and therapeutic potential in the form of biopsy can be taken, or any polypectomy can be done.
Biopsy is not therapeutic. Biopsy is not therapeutic. You can say that you can take a tissue for histological diagnosis.
And any polypectomy can be done, sir. Whereas in a virtual colonoscopy, we are only able to visualize the mucosa and any interluminal pathology.
Is it possible? Is it easy to do virtual colonoscopy in an obstructed growth which is causing obstruction?
No, sir. It also requires bowel preparation, and in the form of if there's residual stools are present, then it can be misinterpreted. So
because if you have stool which you cannot clear, then you will not get good delineation of the mucosa. So virtual colonoscopy is an alternative, but it is not as good a procedure to detect these small secondary lesions as a real colonoscopy is. But if you can't do real colonoscopy, it is the only available option. Okay. So you would do a CT scan. What CT?
CT scan, contrast CT scan, triple patient with a negative oral contrast.
So in the exam, whenever you mention CT at your level, I expect that you should never say CT. You should say full description, which means, for example, in this case, you should say CT of the abdomen and pelvis. Some people may even say CT chest, abdomen and pelvis with oral and IV contrast. Okay. So would you do CT abdomen pelvis? Would you do CT chest abdomen pelvis? What would you do?
Chest, abdomen, and pelvis. Contrast and CT scan of the chest, abdomen, and pelvis. I will do.
What about ultrasound?
Before this, sir, I would like to see the ultrasound also and create serum creatinine and CA level also. Sir, I would like to see ultrasound abdomen and chest.
So as a precaution, I personally would advise that in the exam, whenever you have a patient with any malignancy, it is always safer to start with a chest X-ray and an ultrasound abdomen. Now, in HPB malignancies, an ultrasound important is a must. Because if you see metastasis in the liver, and for that matter, chest X-ray, if you see metastasis in the lung, in most cases, in almost all cases, that is the end of investigation. Because very, very rarely you would still resect in presence of a metastasis. On the other hand, in GI malignancy and more commonly colorectal malignancy, you would still go ahead with resection even if you see metastasis in the liver or even lung, because even they can be resected. But still, it is much safer in the exam and in your clinical practice also to do an ultrasound abdomen, which will tell you not only liver, it will tell you whether you have missed a small amount of free fluid, which will also show you nodes, which can also show you a large omental deposit, which will also show you the urinary tract, especially in case of a CS cecum, CS sigmoid or CA rectum. In cecum and sigmoid, unilateral, rectum bilateral, hydroureter and hydronephrosis. So it gives you a lot of information which makes you better prepared. In almost all cases after ultrasound, you will still do a CT, but you can always defend doing an ultrasound. If you don't do an ultrasound, some examiners will not like it and they would say, why don't you do easy investigation? So make it a habit, make it a routine to mention chest X-ray and ultrasound before you go on with more expensive investigations. Okay. Now, between chest X-ray and chest CT, it is a difference of practice. Some groups would not do chest CT, but more and more groups now are doing a chest CT as a routine in all malignancies. So if you mention that, there is no harm. But isn't it true that for rectal growths, an MRI is better than CT? So why in this case you have chosen CT and not MRI?
Because on sigmoidoscopy, growth is limited to sigmoid colon only. So I would not like to add MRI pelvis in this case because sigmoid and at the level, up to the level of rectosigmoid junction, CT scan with contrast is as good as MRI.
Yeah, again, in the exam, try to make a positive statement rather than a negative statement. So your answer should be that for colonic, for sigmoid, and even for upper rectal growth, CT scan gives as much information or as good information as an MRI. And because I'm more familiar in reading CT scan, and then I can look at the liver and chest also in one investigation, I would do a CT chest, abdomen, and pelvis. When it comes to mid or lower rectum, MRI definitely gives you more and better information, especially regarding the soft tissues, which means the sphincter and the mesorectum as compared to CT. So in that situation, the best combination is CT chest and abdomen and MRI pelvis, which means 2 investigations. So here, because the growth is clearly shown to be beyond the rectum in the sigmoid colon, a CT scan is good enough. Okay. We have the CT report.
And also, I would like to see the CA report.
Yes. So what does the CT show? Do we have the report? Utkarsh, you have the report with you?
Yes, sir.
Yeah.
The CECT showed carcinoma sigmoid colon with local advancement and multiple small perilesional lymph nodes and fat stranding, and multiple lesion in segment 7 and segment 2 of the liver. Largest is 1.5 by 1 centimeter in size. One lesion in segment 2, sir, and one lesion in segment 7. Largest is 1.5 by 1 centimeter. And sir,
Anything?
CEA level was 11.2.
So on the CT, do you need
There is
any
no,
more? Yeah, go
sir,
on.
no other evidence of other than extrahepatic. There is no evidence of any extrahepatic metastasis other than liver mets.
So on the CT, you want to know anything else?
Lymph nodes.
Yes, it's a local advancement for what is adjacent organ involvement. So I would like to see whether ureter is involved or pelvic sidewall and small bowel loop is infiltrated.
So what all organs can be involved in a growth in the sigmoid colon?
It can involve the ureter, any this patient is not hysterectomized, so uterus and vault of the vagina may be involved, may not go up to that lower level, but uterus, then adjacent small bowel loop, and if redundant sigmoid is there, then it may involve the cecum also. There may be adhesion with ascending colon, or it may infiltrate the pelvic side wall, left side of the pelvic side wall. So,
You said vault of the vagina. How would the vault of vagina be involved in a sigmoid growth?
it
What
will
is
not
more
go up to
likely?
that level.
What is more likely to be involved in a sigmoid growth rather than the vagina? Uterus, I agree. Bladder, isn't it? Bladder can be involved. So it is ureter, it could be bladder, it could be small bowel, and sigmoid. A redundant sigmoid can go up to the right side. You can have a lump in the right iliac fossa in a sigmoid growth. It can even involve the right ureter. Usually involves the left, but it can even involve the right ureter depending on, suppose there is a growth at the tip of the sigmoid loop and it is a redundant loop which is lying on the right side. So these are all the organs which are involved and which you can get some information from the CT scan. So when they say locally advanced, you would like to know what exactly they mean by. Whenever you are given a report, when you are asked to analyze, you should point out the deficiencies in the report and you should say this is more information that I would want. How do you explain the CA level? What do you make of it?
CA level is elevated, but given the imaging picture of bilobar metastasis in the segment 2 and segment 7, it is not much elevated. So we cannot, but it is more than normal size, so it is elevated.
You should say that not all patients with colorectal cancer and not all patients with liver metastasis will have elevated CA level. Some of the tumors are what are known as non-secreting. So this tumor is probably a non-secreting tumor, which you can say that it doesn't help me at this stage. If it was high, it would have helped me. But still, you would like to keep this value with you as a baseline because we know that when the patients recur, either locally or in the form of metastasis, the recurrent tumor may become secreting tumor. So if in follow-up the CA level is high, that will be strongly suggestive of a recurrence or metastasis. Primarily, CA level is not of much value, except that if you have a very, very high CA level, some groups use that as a cutoff to probably do a PET scan, which otherwise is not indicated, not done as a routine in colorectal cancer. So some people would use CEA as a screening test for a PET scan.
Yes.
So I think I have to close at 9.
Sir, cutoff. Good evening.
Yes,
sir. Cutoff value of the CA to do the PET scan, 200 or 400? I forgot.
Check some of the guidelines. I don't exactly remember, but probably different groups will follow different levels. Just check. I don't want to give you a wrong answer. But many groups would use CEA. I don't know whether it figures in the guidelines, but many groups would use CEA for asking for a PET scan. So indications for PET scan in colorectal cancer would be high CEA, and when you are thinking of doing exentration, a major procedure with high morbidity, when you are planning a liver resection. So before that, you would like to make sure that there is no extrahepatic disease and a recurrent tumor. If you have a recurrence, if you are planning a re-resection, then most groups would like to do a PET scan. So these are some of the indications for PET scan in a colorectal cancer.
Okay, so thank you, sir. Thank you.
So what we can do, the next session, we can continue and discuss the management of this case. So just make a summary of the, so that I remember, of the diagnosis and the investigations, and then we can take on the discussion from there, that how we will manage this case. So let me tell you about the next class. Tomorrow I have a social function, 7th again, 8th and 9th, I'm not there. So the earliest possible will be 10th.
Okay.
Earliest possible will be 10th. So maybe around the same time, but one of you can check with me on 10th morning.
Okay.
Okay. And in the meantime, send me a mail, all of you, vkkapoor.india@gmail.com. Just write rectum in the subject of the mail. So I will send you the chapter on rectal bleeding from my book. But this is a proof. So this is for personal use only. Don't send it to anybody else. Otherwise, the publishers will be after me.
Sir, one small
Yes,
request, sir,
yes.
regarding portal hypertension. Last case you asked for the request, so sir, I have mailed you. If you can send the chapter, sir.
Yeah, I will. I wait for the whole week because not every one of you asks for it in the week. So I will send it at the end of the week.
Okay, sir. Okay, thank you.
Yes, let me check whether your mail address is there. So last was what? Last was portal hypertension, no?
Yes, sir.
Yeah, let me just check. Yeah, Utkarsh Shah.
Yes, sir.
Yes,
Yes.
yes, your name is there. Your name is there. Okay. I will send it around Saturday or Sunday.
And no issues, sir. No issues. Your
Yes.
convenience. Thank you.
Okay.
And sir, thank you so much for this special session. Thank you.
Good night.
Thank you, sir. Thank you very much. Good night.